Good morning, ladies and gentlemen. I ask myself, number one, why I am invited here, and number two, why I am invited to replace John Kemp as a chairperson. Most probably it has to do with my 2-year training in psychiatry, which usually helps to keep the speakers on time. Now, my task is to put the framework, what is available for stroke prevention and atrial fibrillation. And I think this is a task of a neurologist who sees the consequences of atrial fibrillation every day. For everyone who is not from Germany, I wanted to show you where I come from. Essen is in the middle of a metropolitan area. This is the industrial heart of Germany. It's about 60 kilometers long, 40 kilometers wide, 6 million people. So it's a population of Switzerland in one area. The only difference is flat, and it's much cheaper than in Switzerland. Now coming back to John Kemp, I'm short of one conflict of interest compared to John Kemp, but I realized yesterday that my St. Jude's conflict of interest is in the migraine slide and not in the stroke slide, so I will add it in future, and now I match John Kemp in this respect. Now, let me remind you what are the goals for anticoagulation therapy in atrial fibrillation. The primary goal is to prevent this. Hemorrhagic stroke and cardioembolic strokes are terrible strokes. So mortality is 20%, and the percentage of people who are permanently disabled ending up in nursing homes is 60%, 60. Now there is a downside of therapy, in particular antithrombotic therapy, and this is hemorrhagic stroke. Now when all this started with the randomized trials, this was put in renal and cardiovascular at the FDA. And these guys, they have ideas about myocardial infarction and kidney failure, but they had no idea about stroke. And this is why they put two different conditions in one endpoint. One endpoint is what we want to achieve. This is to prevent ischemic stroke. But they also put the complication of the therapy in the same endpoint, which doesn't make sense. How do you explain this to a patient? I think it's okay for specialists, cardiologists, neurologists, they get the concept. But this was an FDA decision, and EMA unfortunately then followed the path of FDA. Now, what is our role as stroke neurologists? Very simply, whatever you do wrong, we will see the consequences. Because if a patient with atrial fibrillation is not treated, is ineffectively treated with antiplatelet therapy, or is poorly treated, for example, with warfarin INR below 2, we will see these devastating cardioembolic strokes on our stroke units. But on the other hand, if someone is poorly controlled on warfarin, has an INR of 6, this person will end up on my intensive care unit with an intracerebral bleed or intracranial bleed. So whatever happens to these patients, I will see it. And this shapes your view of the world, I can tell you. Now let's move a little bit into the past of stroke prevention in atrial fibrillation. And it's interesting that all this basically started in 1952 when warfarin was approved for human use, but it was primarily for the prevention of DVT and not primarily for stroke prevention in atrial fibrillation. And it took a long time until the first randomized trials were published. This was in 1990 when it became clear that warfarin is effective in stroke prevention compared to placebo and also compared to aspirin. And now we have a totally new world because we have now 4 novel anticoagulants. 3 of them are approved. Edoxaban just got approval for the 60 milligram dose in the United States, and they are waiting approval in Europe. So this is a dramatic development in the last few years. I always like to show this slide to my medical school, to my medical students when I teach neurology. Warfarin is incredibly effective in preventing stroke. The average risk reduction is 64%. But if patients are kept within an INR of 2 to 3, the risk reduction is 80%. Numbers needed to treat is about 12, 8 to 12. And there is nothing in stroke prevention which is as effective as oral anticoagulation in people with atrial fibrillation. Unfortunately, aspirin is almost not effective. The meta-analysis shows there is a risk reduction of 19%, and this is statistically not superior to placebo. And unfortunately, the bleeding risk on aspirin is identical to the bleeding risk of novel anticoagulants. So it's basically no benefit. My son would say aspirin is mega out. Now, what is the reality? What we learned from the large registry is that a lot of patients are not anticoagulated. And this has two ends. The one end is the high-risk patients. The higher your risk, the more unlikely is it that you get anticoagulated. On the other hand, we have many patients with a CHEDS or CHEDS-VAS score of 0 or 1 who are anticoagulated. And we have to do a lot of teaching to teach doctors how to deal with this problem. Who are the ideal candidates for anticoagulation? Now, this is a slide taken from the province of Ontario in Canada. And in contrast to the United States, Canada has a very well-developed healthcare system if it comes to stroke treatment. And what this slide shows is the following. These were people who were admitted to a stroke unit with an acute ischemic stroke. And all of these people had atrial fibrillation. The patients knew that they had atrial fibrillation, and the treating GP knew that his patient had atrial fibrillation. What was the treatment at the time of stroke? Well, as you can see in the gray area, 30% of these people were untreated. They had nothing. So I think the highest priority we have is to identify people with atrial fibrillation and get them treated. Number two, 30% of these patients were treated with aspirin monotherapy. And aspirin, as I told you, is basically not much better than placebo. So we have to switch people on aspirin to anticoagulation. Now, it seems the good news is 30% were on warfarin. But unfortunately, in these patients, the INR was below 2. They were poorly treated. And we have to switch these people, which are most of the time out of the therapeutic range, to novel anticoagulants. And ladies and gentlemen, at the end of the day, only 10% of these patients were properly anticoagulated. Now, you can say this was 5 years ago, but we have recent data from the German stroke registry, and nothing has changed. The majority of patients admitted to our stroke units with cardioembolic strokes are untreated, are on aspirin, or are poorly controlled on warfarin. The major risk factor which we should add to the CHEDS-VAS score are dentists, because they will stop anticoagulation and not resume it, and similar things happening. So we have a lot of work to do to prevent these strokes in future. So let me summarize. What we know is aspirin is almost not effective, and we all know that warfarin is very difficult to handle. This is a downside for many patients in our healthcare systems. What is the present? Fortunately, we have now novel anticoagulants. There are 4 of them, as you know, dabigatran, apixaban, rivaroxaban, and edoxaban. And if we look at the totality of the information we have, we can say that for stroke prevention, we have drugs that are superior to warfarin, and this is a high dose of dabigatran and apixaban, and we have drugs that are non-inferior to warfarin, and this is a low dose of dabigatran, rivaroxaban, and a high dose of edoxaban. The FDA rightly did not approve the low dose of edoxaban because it's inferior to warfarin in preventing strokes. But from my standpoint, this is wonderful, but what I really care about is hemorrhagic stroke. And we have a dramatic reduction in hemorrhagic stroke with the novel anticoagulants. The risk reduction is between 40 and 80%. And I went through the charts of the last 18 months. We didn't have a single case on our intensive care unit with a cerebral bleed on a novel anticoagulant. But we had dozens of patients bleeding into the brain on warfarin. Why is this relevant? This condition has a mortality of 50%. Half of the patients will die. By the way, if they are on triple therapy, anticoagulation, aspirin, clopidogrel, the mortality is 80%. You have almost no chance to survive on triple therapy if it bleeds into the brain. Now, my business is secondary stroke prevention, people who had a TIA stroke and have atrial fibrillation. And until recently, this is 15 years ago, we didn't have scientific evidence that anticoagulation works in secondary stroke prevention. And this was a trial done in the Netherlands with 1,000 patients who had a TIA or minor stroke, and they were randomized in 3 groups: placebo, This was the last placebo-controlled trial, aspirin or oral anticoagulation with warfarin. Now, compared to placebo, aspirin had a relative risk reduction of 14%, which was statistically not significant. So in secondary stroke prevention, aspirin is not effective, but warfarin was highly effective. The risk reduction was 66%, and again, if patients were kept in an INR between 2 and 3, the risk reduction was 80%, 80, highly effective. Now, what's about the novel anticoagulants? In all of these trials, we had subgroups of people who had a TIA stroke, and we put them together in this meta-analysis, and on the left side, you can see the risk reduction for stroke and systemic embolism in secondary stroke prevention, and the risk reduction compared to warfarin is 15%. So the novel anticoagulants are superior to warfarin in secondary stroke prevention, but we maintain the dramatic reduction in the risk of hemorrhagic stroke. There is a risk reduction, as you can see, of 55%. So we have all the benefits. In addition, we have reduced mortality, and we have a reduced rate of major bleeding complications in secondary stroke prevention. Now, we have many problems, and because this meeting is on LAAO occlusion, I picked out one, which is prior intracerebral bleeds. So these are either people who have a history of intracerebral bleed and develop atrial fibrillation, or people who had an intracranial hemorrhage on anticoagulation. Can we anticoagulate these people, and do we have options? The other options will be discussed today, and I give you my opinion at the end of the day, what I think, what are the options that we have. Now, as you can imagine, all of these patients were excluded from the randomized trials, so we have no information from the randomized trials. And the decision whether these people could be anticoagulated in future or not depends on the etiology. I give you an example. If someone comes in and has a history of 5 years of uncontrolled hypertension, has a basal ganglia bleed on warfarin and now recovers very well, and now his wife takes care of the medication and the blood pressure is well controlled after 2 months, this person can be anticoagulated. But if a person has a cortical bleed, as you can see on the left side, this person has a very high risk of recurrent hemorrhage, and these people cannot be anticoagulated long term. It's perhaps okay in the context of a procedure to do this for 4 or 6 weeks, but not for the rest of the life. If someone has a subdural hematoma, and this is successfully operated, this patient most probably can go back on anticoagulation. But this is a condition where a neurologist and a cardiologist have to discuss whether it's safe to put this patient back. Now, if you look at the left slide, you see this about 100 dark spots. These are microbleeds in the cortex. And this is an indication of a condition called amyloid angiopathy, a condition with a very high bleeding risk into the cortex. The clinical symptoms are early cognitive impairment, gait impairment, and cerebral bleeds. And these patients can never be anticoagulated. So we have no options here. Now let us look into the future. One thing we were terribly afraid until recently was the fact that for the novel anticoagulants we did not have specific antidotes, but they are available now. This is the antibody against the bigatron. It is in the trial at the moment. 96 patients were already treated in the context of this trial. These are patients who come in with major bleeds or need urgent surgery, and my prediction is that the approval of this antidote will come in the summer. So the FDA said as soon as we have the critical number of patients, they are willing to decide within 4 weeks whether the antibody will be available. And there are others for the 10A inhibitors. They are a little bit behind in development. But my prediction is at the beginning of next year, we will have these highly specific, highly effective drugs to stop bleeding. Unfortunately, the companies are not willing to show the videos from pig experiments because of the animal rights people. But if you see how the bleeding basically stops 3 minutes after the infusion of this compound, this is very impressive. And we see basically the same in the ongoing trials. That's very reassuring. Now, we all met today because of this, and I will not discuss this. I will only give you my opinion at the end of the day. And these are, I think, a few things that will be discussed today. What is the indication? I'm still waiting for, let's say, a joint guideline between stroke neurologists and cardiologists. A question that you have to discuss, are all devices the same or are there differences? Should we only look at secondary stroke prevention? There will be an interesting debate whether this should be done in primary stroke prevention. I have a very clear opinion about this. Do we need more trials? Definitely. We always need more evidence. We need evidence from perhaps our subgroups of patients. And the other things is, and there will be a lecture on this, antithrombotic therapy prior to, during, and how long after LAA occlusion. So with this, hopefully, I could set the scene for what we will hear today, and we will discuss the two options that we have, antithrombotic therapy and occlusion of the left atrium. Thank you very much.
Thank you.